Hello, everyone, and thank you for attending today's webinar, Diagnosing C. difficile, New Guidelines, Familiar Challenges. This is Zach Crowther from Cepheid, and I have the privilege of being your moderator today. Before we begin, I'd like to cover a few housekeeping items. At the bottom of your audience console are multiple application widgets you can use. If you have any questions during the webcast, you can click on the Q&A widget at the bottom and submit your question. We expect to have some time at the end of the presentation for Q&A, where we'll answer as many of these questions as possible. A PDF copy of today's slide deck is available in the resource list widget that looks like a green folder at the bottom of your screen. There's also a link to past C. diff webinars that are available for on-demand viewing in that same green folder if you're interested. If you're having trouble seeing the slides, you can always expand your slide area by clicking on the maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. For any technical difficulties, please click on the Help widget. It has a question mark icon and covers common technical issues. If you feel a colleague would benefit from viewing this presentation, you can click on the blue Refer a Colleague widget to forward registration details. And an on-demand version of the webcast will be available approximately one day after this live webcast and can be accessed using the same audience link that was sent to you earlier. PACE credits are available for attending this presentation. Please be sure to fill out the survey, also located at the bottom of the console at the end of the webinar, to request credit if you're interested. Okay, that concludes the housekeeping announcements today. For those of you who may be just joining us, welcome to today's webinar, Diagnosing C. difficile, New Guidelines, Familiar Challenges. Our webinar platform today gives us the opportunity to conduct instant polls of the audience. So I'm going to roll out one of those right now as I introduce the speakers. You should see that interactive slide popping up on your screen momentarily, so go ahead and select an answer if you'd like to participate in the poll. So we're excited and grateful to be joined today by two excellent speakers representing two different functional areas that play an important role in C. diff diagnosis and treatment. Dr. Nathan Ledebour, who will be giving the first presentation today, is an associate professor of pathology and the medical director for clinical microbiology and molecular diagnostics at the Medical College of Wisconsin in Milwaukee. Giving the second and final presentation today will be Dr. David Nicolau. Dr. Nicolau is a PharmD pharmacist and director of the Center for Anti-Infective Research and Development at Hartford Hospital in Connecticut. The topic of C. diff diagnosis has been a complex and at times controversial one over the past few years. The recent updated guidelines from IDSA and SHEA provide yet another perspective on the topic and give us an opportunity to take another look at the subject from a new angle. So the question we posed to our speakers today was, how do you handle C. diff diagnosis, treatment, and infection control in your institutions, and what, if anything, has changed with the publication of these new guidelines? I'd like to thank both speakers for joining us today. We're going to close out the instant poll now and let everyone see those results. And with that, I will hand it over to you, Dr. Ledebour.
Well, thank you, Zach. And good afternoon to all of you in the East, and good morning to all of you in the West. As our poll indicates, one of the areas that we've seen a great deal of movement to over the last several years is the movement from EIA-based testing to PCR-based testing for the diagnosis of C. difficile. For those of us that perform PCR only in our laboratories, there have been significant new challenges or significant discussion around the utility of PCR, particularly around the specificity. And 2018 has really been no exception to this process. To begin my presentation, these are my disclosures, and my outline really starts to address the issue of the challenges that we've seen in 2018 with the release of new NHSN reporting guidelines, as well as the release of the 2017 IDSA SHEA guidelines for the diagnosis and management of Clostridium difficile. So the outline of the presentation will briefly review some of the challenges associated with C. difficile testing. We'll talk about some of the changes in NHSN, or National Health Safety Network, reporting. We'll talk about the IDSA guidelines, at least from a diagnostics perspective, and discuss both what the guidelines said as well as what they did not say. And finally, we'll conclude with a discussion on how healthcare facilities can begin to adapt to some of these changes. But really, as we start to think about the challenges of C. difficile, the same basic question that we've struggled with for many decades continues to persist in the arena of C. difficile testing. And the biggest challenge associated with C. difficile testing is, should my testing scheme, or is my testing scheme, optimized for sensitivity, or is my testing scheme optimized for specificity? This is largely due to two primary approaches that are utilized for the diagnosis of C. difficile. We can detect the organism, or we can detect the toxin. By detecting the organism, either through culture or molecular testing or other antigen-based tests for the organism, we optimize for sensitivity. So we can find the largest or the most patients that may be carrying or may be ill with Clostridium difficile. By contrast, by detecting only the toxin, generally through tissue culture methods or through antigen-based assays looking for the toxin, we can optimize for specificity, looking for those patients that are more likely to be carrying toxin and thus more likely to have disease, but there's a risk that we may miss something. And this was nicely highlighted in a study that's contributed to a great deal of conversation over the last decade, or over the last several years, published by Chris Palage and colleagues at the University of California. And in this study, they looked at outcomes associated with patients that were toxin positive, PCR positive, compared to toxin negative, PCR positive, and those that were negative by both toxin and PCR-based testing. What they largely find is that PCR, while more sensitive, tends to be more often or can be associated with treatment of patients that may be colonized or may be less sick as compared to those patients that were toxin negative, PCR positive. Now, the interesting thing about this study, though, is the fact that while they look at these two different populations, this was largely a retrospective study, and as a result, they did not necessarily see different levels of treatment in these two patient groups. Much of this discussion was nicely highlighted in a point-counterpoint that was also recently published in the Journal of Clinical Microbiology. And this point-counterpoint really addressed the issue of what is the optimum approach for detection of Clostridium difficile, with those suggesting that PCR was the best approach, written by Ferric Fang, and the counterpoint written by Chris Palage and Mark Wilcox, suggesting that a multi-tiered approach may be the better approach. What both sides ultimately agreed upon was several points. The first point that they primarily agreed upon was that NAT-based testing often increases reporting of Clostridium difficile infection rates at healthcare institutions. And this is not particularly surprising. Use a more sensitive test, and you're more likely to find more cases. One of the biggest points that both sides agreed on in this counterpoint was that pre-analytical values or pre-analytical factors contribute significantly to the overall positivity rate and contribute significantly to whether the test was used appropriately or not used appropriately. And we'll spend a lot more time talking about this as we go through the presentation. They also agreed that while NAT and culture-based methods are more sensitive, they tend to be a bit less specific than toxin assays, whereas toxin assays are less sensitive, with some studies reporting the sensitivity of toxin assays approaching 20%, but they are more specific, identifying only those strains that are producing toxin. And ultimately, as we go throughout this discussion today, I'm going to make the argument to you that we may not know the best strategy in relation to, should we optimize for sensitivity, should we optimize for specificity, or do we need to achieve a balance between both sensitivity and specificity in identifying those patients that truly have Clostridium difficile colitis? Finally, this counterpoint also suggested that patients testing positive by NAT without active Clostridium difficile infection may, in fact, be an important reservoir for the spread of C. difficile within the healthcare institution. So this is a really important point because this begins to suggest that patients themselves may be a significant reservoir for Clostridium difficile, causing spread within the healthcare environment. As we shift to some of the changes that occurred in 2018, one of the first changes that we saw, and probably one of the most impactful changes that we saw, was a change in how facilities report information into NHSN, or the National Healthcare Safety Network. And while this change may sound a bit bureaucratic, it's actually incredibly important in terms of how facilities calculate their overall infection rates, particularly related to hospital onset infection rates. Prior to 2018, facilities had to report any positive C. difficile test. So if your laboratory was running NAT alone, any positive NAT was reported and was considered to be a clinical lab reportable event. Under the 2018 guidance, NHSN shifted how they were accepting information, particularly from hospitals that were using a multi-step approach. So if your healthcare institution is using NAT and following the NAT with a toxin result, you now report your overall interpretation or your final result, not simply the NAT positive or the toxin being positive. And this is a significant shift for those institutions that use a multi-tiered approach because it takes into account the overall institutional interpretation. Now, there's other critical components to NHSN reporting that we have to consider. First, facilities can choose to monitor C. difficile where testing in the laboratory is routinely performed only on unformed stools. So this is incredibly important because for those institutions that may be doing some form of surveillance, this is not reportable. Equally important, in the NHSN guidelines, NHSN says that if you are performing active surveillance, this should not be reported into NHSN as community-acquired C. difficile, and if you are reporting it, NHSN would consider this to be cheating. The NHSN guideline also suggests that while all locations can be reported, facilities must separate between testing that's performed in the inpatient environment versus testing that's performed in the outpatient environment so that appropriate calculations can be made about both the expected and the institutional infection rate. And as I said to you, the big change for 2018 was that when you're using a multi-test based approach for the diagnosis of Clostridium difficile, only the final result is reported rather than simply the screening result or the final result being reported. Now, there's one word of caution that you need to consider as you're thinking about these changes and you're thinking about how to respond to these changes. If you're using a multi-tiered approach, or you're starting to think, hey, maybe I can reduce my Clostridium difficile infection rate by using a multi-tiered approach, you have to also remember that there's two components attached to your rate of Clostridium difficile. There's your hospital's rate, simply calculating the number of tests performed combined with the number of hospital days combined with your overall positivity rate, and then that's divided by the institution's SIR, or standardized infection ratio. And this is the ratio of what is expected to be your Clostridium difficile infection rate based upon the patient population that you serve, based upon the number of beds that you serve, and based upon the number of patient days, as well as based upon the test that you're using. So if you were using NAT and you were reporting based upon NAT in 2017, your standardized infection ratio was corrected for an expected higher positivity rate associated with NAT. Compared to 2018, if you're using an algorithm-based approach and you're reporting based upon the final interpretation of the algorithm or the NAT plus the toxin result, your SIR, or your expected infection rate, may in fact be reduced because you're now doing your final interpretation based upon the combination of a sensitive and a specific test, which as a result would potentially reduce your overall infection rate. Now, none of us have seen our SIRs for the first quarter of 2018 because they haven't been released yet. But this is an important thing to continue to pay attention to as we consider what testing methodology we're going to use. Now, you may wonder, what's all the discussion about? Why are we talking about SIRs and about public reporting? Our institution does a great job at reporting C. difficile and capturing it. Well, this is an interesting study published in the American Journal of Infection Control, which looked at some of the clinical challenges associated with Clostridium difficile testing. And in this particular study, the institution identified 490 healthcare onset Clostridium difficile infection lab ID events during a total of 452,587 patient days. For each of those positive events, infection control then went back and reviewed whether the testing was considered to be appropriate and if testing was considered to be appropriate, whether the healthcare onset Clostridium difficile infection was a true positive, or if inappropriate testing was used or delayed testing was used, then this was considered to be a non-true result. They classified inappropriate testing to be testing within 2 days of initiating a laxative in a patient. They also classified inappropriate testing to be patients that didn't have more than 3 episodes of diarrhea. And the interesting thing that this particular study found was that of all of their healthcare-associated Clostridium difficile events, approximately half were true hospital-onset C. diff events, whereas about 42% were classified as non-true. The vast majority of the non-true healthcare onset Clostridium difficile events, 90.5% of these events were reported as a result of inappropriate testing. The patient was on a laxative, or the patient didn't have more than 3 episodes of diarrhea. An additional 9.5% of this population was a result of a non-true hospital-associated CDI event, largely because testing was delayed. So the test wasn't ordered within 3 days of admission, in which case it would have been classified as a community onset event, but was instead ordered in more than 3 days after the admission, and as a result was classified as a hospital onset event. So this is really important data as we start to look at how are we reporting these events and how are we correcting for these events. Now, the second big change for 2018 was the introduction of the new IDSA-SHE guidelines. And there were a number of areas where we saw significant shifts in the guidance. And probably one of the biggest event places where we saw a shift in the guidance, and the area where it likely impacts the hospital laboratory the most, is in changes in the recommended testing strategy. So the shift in the testing strategy was a shift from exclusively running NAT or exclusively running a 2-step algorithm to more of a epidemiologically driven guideline. So as you can see, and this is one of the figures from the guidelines, the first factor that you need to consider when evaluating what testing methodology you're going to use comes down to, are you doing a good job at the pre-analyticals? So can you, as a healthcare institution, control for not receiving specimens from patients that are on laxatives? Can you control for and can you ensure that testing is only performed on patients that have had more than 3 unformed stools within a 24-hour period prior to testing for Clostridium difficile infection? If the answer to those questions is yes, then the guidelines suggest that NAT alone or a stool toxin test as a part of a multi-step algorithm is sufficient in both sensitivity and specificity. However, for many laboratories, the guidelines acknowledge that this may not be possible, that the lab or the institution may not have the ability or the political capital to be able to restrict performing testing on patients that have not been on laxatives or patients that have had more than 3 unformed stools. And in those cases, the recommendation from the guideline is that you would perform either a stool toxin test as a part of a multi-step algorithm or a NAT test plus a toxin test as a combination together. Now, there were other important changes that happened as a result of the guidelines. One of the other important changes is that they now suggest patients with unexplained new onset diarrhea consisting of greater than 3 unformed stools are the preferred target population. There was not a preferred target population that was identified in the last set of guidelines. There were other areas in the guidelines where we knew and the literature strongly supported these practices that are continuing to be emphasized as well. And one of those areas is performing repeat testing. The guidelines now say that the guidelines now confirm with strong evidence that repeat testing should not be performed within 7 days during the same episode of diarrhea. And the guidelines also suggest that we should not be testing stool from asymptomatic patients except for epidemiological studies. And finally, one of the other major shifts in the guidelines, and this is particularly important for our infection prevention colleagues, is that in routine or in endemic settings, performing hand hygiene before and after contact with the patient with CDI and after removing gloves should be done with either soap and water, or they have now added an alcohol-based hand hygiene product that can also be done. And this is a significant shift. And the reason for the change in the guidelines was largely based upon, in the former version of the guidelines, they suggested only using soap and water. And they added an alcohol-based hand hygiene product because there was a great deal of lack of performance of hand hygiene with soap and water. So this basically would suggest that at least we can get some form of disinfection of the hands, as well as new evidence that may be starting to suggest that the alcohol may be partially killing the organism. And again, this is based upon weak evidence, and this is an area where significant additional study needs to be performed. So what are laboratories to do as a result of all these changes? We've seen many changes in how we report. We've seen many changes in how we should be doing testing. Probably the first step is to stop, take a breath, and understand these are very manageable changes. And really, this is a lot about test stewardship. The ASCP for several years have suggested that we as laboratories need to provide the right test for the right patient at the right time and at the right cost. And I can tell you that implementing appropriate test stewardship can be incredibly effective in limiting who gets Clostridium difficile testing to the most appropriate patients. This is a study published by Dries and colleagues. It was originally published as an abstract at the 2017 ID Week meeting, was subsequently published in the Open Forum of Infectious Diseases, and looked at the question of, can test stewardship work? And in this study, they evaluated the effectiveness of an alert, so basically a notification to the physician, compared to a hard stop. What they found was that while alerts can initially be quite effective, the attention to the alerts ultimately wanes over time. So this is basically fatigue. So every time you log into your email, you get notices about things. And over time, we start to pay less and less attention to this. Well, the same is true for our healthcare providers. If every time that they order a C. difficile test, or every time the algorithms don't identify more than 3 episodes of diarrhea or identify laxative use, what can happen is the provider continues to be alerted by this and starts to, yeah, I know what you're telling me, I still want the test anyways, and ignores the alert. This study suggests that if you can utilize the hard stop, it can ultimately be much more effective than an alert, and it can prevent the waning of attention over time. So in this particular study, they fired a hard stop based upon the number of episodes of documented diarrhea, whether or not the patient had been placed on laxatives or not, and whether or not the patient had an elevated temperature. And when they implemented the hard study requiring the physician to document the reason for moving forward with testing, you can see, as indicated by the arrow, that the number of C. difficile tests ordered dropped off significantly, as well as the number of episodes, the number of episodes of healthcare diarrhea or healthcare-associated Clostridium difficile diarrhea ultimately both decreased. So this study, at least, is one early study to suggest that in fact, lab stewardship can have an important impact related to positivity rates. We in the lab can also help a great deal. And one of the places that we in the lab can help is ultimately in how we receive specimens. For those of you that may have watched Scrubs years ago, as Scrubs used to tell us, everything comes down to poo. And so when we get specimens into the laboratory, we need to evaluate the specimens to make sure that they take the form of the transport container, or as the Bristol stool chart indicates, really those type 6 and type 7 specimens are only those that are the only specimens that we should be testing. We also can establish acceptability criteria. We can require that specimens be submitted within 7 days, or we can require that specimens submitted within 7 days of a previous test should not be repeated. And there are some centers that have even gone farther out than this, particularly on positive NATs, where they're not performing retesting at 14 or 21 days. Again, these are very limited centers, and I would make the argument that this particular practice needs a great deal of additional study. As we previously talked about, we can also use IT solutions to help through things like best practice alerts, as well as hard stops, or in many institutions, we can even require mandatory consultation with either ID or the lab director if testing has been flagged as an inappropriate order. But again, politically, this can be a bit difficult to overcome, but can in fact improve the culture of healthcare institutions. Finally, we can also use our IT department to help, as well as I want to emphasize the importance of education of our providers. So this is a study that was published by the Johns Hopkins University in Infection Control and Hospital Epidemiology back in 2015. And what they found was that when they educated their providers and they looked at appropriateness of ordering in the baseline or the pre-education period of time, as well as in the intervention period of time or the post-education period of time, they were able to increase appropriate ordering significantly compared to the baseline group. And finally, as I hand the presentation over to Dr. Nicolau, we can also utilize appropriate antimicrobial stewardship, ensuring that the right patient gets the right antibiotic and the most narrow antibiotic at the right time in order to prevent the spread of Clostridium difficile within our hospitals. With that, I'll say thank you for your time, and I'll hand things over to Dr. Nicolau.
Great. Good afternoon. Dave Nicolau from Hartford Hospital. And that was a tremendous start to this webinar. Nate, thank you very, very much. My disclosures are outlined for you here. And as we get into the issues of guidelines, we're going to be talking certainly about what other changes and perhaps some opportunities with respect to the new C. diff guidelines. But my colleague ended in a perfect place relative to antimicrobial stewardship. And so I think we also need to appreciate the ongoing changes in the context of that aspect of management. So when you think about guidelines, and these are certainly relevant to the C. diff guidelines, but you have to ask yourself, what do they provide and what don't they provide? And certainly many of these guidelines, the most contemporary guidelines, are multidisciplinary, and they are a contemporary review of the management and the disease state, providing important opportunities and embracing not only issues related to treatment, prevention, but certainly nuances in diagnosis, as my colleague has provided you. You have to also understand that they may not provide everything that you want to do relative to managing the disease. And one of the things that guidelines generally don't do very well is tell you how to operationalize, the guidance and actually make it work at your place. So this is infinitely important. Institution-specific value propositions, Nate talked about, whether you have the infrastructure to do some of these things, whether you have the clout to make it happen with respect to stop orders or stop testing. And inclusion of the most recent therapeutic advances may or may not be in the guidelines, and I'll provide you one example of that. Perhaps most importantly, it's important for us to recognize that these are guidelines, not guidelines. And what that means to me is that we need to adapt this guidance to our patient population and our institution-specific requirements. And we appreciate that even within a given institution, we can have pretty diverse populations that require very intricate and diverse treatment approaches. And then implementation for a guideline like the C. diff, I think, is intertwined and intermingled in the guidelines and the stewardship programs within hospital. We appreciate that with the newest stewardship guidelines that were published in 2016, there's been a slight change in philosophy. And the change in philosophy is to move more to a syndromic approach. That is in consideration of the entire patient and the process of care. And so what we want to appreciate is we want to focus on the components of care, which, again, for many of us in the stewardship arena, may be medicine, may be a test, but we don't want to lose sight of the overall quality and the overall process of care, and importantly, the cost of care. And what is happening now that stewardship has become ingrained in our hospital processes as of 2017, and we have CMS involved and we have JACO involved, over time, and I think this is going to happen with some pace, we're going to be moving from process-related measures, days of therapy, defined daily doses, to issues related to outcomes, length of stay, overall cost of care. And I think this is going to be beneficial for many of us in hospital because we're going to be adding additional value to overall quality and cost of care, and there's going to be less emphasis on some of the components of cost as we know it. This is an opportunity when we're talking about syndromic approaches to think beyond the choices of medicine, and the importance of diagnostics, could be imaging, and a variety of other things that might go into a best practice philosophy for the management of a given disease. Easier to provide education, and Nate made a great point that if you want people to change, you have to educate them, provide specific opportunities, and the syndromic approach within a facility allows these interventions to occur and hopefully allows them to grow relative to educational opportunities. And again, learning should be equal to sustained change. And we know that change in practice behaviors takes a tremendous amount of effort. For those of you who are looking, from an antimicrobial stewardship perspective and looking for some support of some of the things that you're doing at hospital or some of the things you'd like to do at hospital relative to antibiotics, I just call your attention to the focus of the guidelines relative to minimizing the frequency and the duration. It says high-risk antibiotics, but I think the philosophy for most of us would be to decrease the frequency and duration of all antibiotic therapy. That's the goal. Implement a stewardship program as a mechanism for making this happen. And again, we have limited time at hospital, right, relative to changing practice. So there's been some suggestion that looking at the high-risk antibiotics, agents like quinolones, clindamycin, and the cephalosporins, would be reasonable targets to start with. But I want to make the emphasis that we really want to decrease the overall antibiotic pressure at hospital by choosing the right agents, as Nate said, and using them for defined periods of time. The other important aspect that's been highlighted in the CDI guidelines is the idea that some of these potential stewardship interventions may not be antimicrobial. And there's a couple of points here. One about the utility of PPIs and the fact that not everybody that comes to hospital should be on a PPI, and not everybody that leaves should leave on one. And if there's an opportunity to mitigate something that may be epidemiologically associated and impactful for CDI management, we should try to get rid of it. There's also a statement about the utility of probiotics in patients for primary prevention of CDI, and this is an ongoing discussion, I think, in many of our hospitals. It's for the reasons that we're talking about interventions across the spectrum, and it starts with the right, patient profile. It starts with the right differential diagnosis. It involves both antibiotics and non-antibiotic interventions. I asked the question, is antimicrobial stewardship, is that the right name for this process? We have been talking more and more frequently about disease state management, or maybe appropriately, best practice. When we sit in on other departmental processes, nobody talks about stewardship in cardiology or gastroenterology. They talk about best practice for managing patients. And I think this is a strong philosophy. Take the issue of management of a patient. It doesn't say management of a patient with C. diff. It says management of a patient with diarrhea in hospital. What's the initial assessment? The likelihood of infection. The need for the diagnostic approaches and understanding what the limitations are of these diagnostic approaches, focusing on issues of rapid and sensitive tests to provide guidance to the clinicians. The need for antibiotic therapy if everything goes down the road of its infection, and the importance of infection control. So the concept of best practice links in, I think, the appropriate players and certainly goes beyond simply the concept of antibiotic management. When we think about patients with diarrhea, we have to appreciate that not all diarrhea is due to infection, and certainly not all of it is due to C. difficile infection. And we have to ask ourselves, to explore alternative explanations. We have to appreciate at the same time that if you were to have an infection with CDI, especially in a compromised host, that this could be a rapidly problematic infection. And so we do need to appreciate the important issue of rapid recognition and the appropriateness of empiric therapy in this patient population. And then the community-based CDI, is an area, I think, of increasing challenge. We are seeing patients that would be considered historically to be low risk presenting with CDI. And so that requires a different algorithmic approach and maybe a concern about best practice in patients coming from community versus the development of diarrhea in patients that are in hospital. The goals of testing, as outlined, are to identify cases of CDI, and certainly we want to provide, our clinical colleagues with the most information most quickly to drill down in definitive therapy. But it's also important for a whole host of reasons to rule out those patients with diarrhea that don't have a CDI, and to not give them a therapy that may not be required, to not put them in isolation that might not be required, to initiate specific treatment plan for these patients. And again, can't say enough about the role of infection control, both in the initial phase of management of disease, and then we'll make a comment about the potential role of infection control on the follow-up. There has been much discussion, certainly before the guidelines, and there will continue to be discussions after the guidelines about the appropriateness of testing. And I think my colleague outlined the important concerns for that. And when I visit hospitals and talk to my clinical colleagues, sometimes we're so focused on what's the right test that we haven't been asking frequently enough who to test. And again, the guidance will provide some important supplemental information. Much of this are things that you are already quite aware of, and persons with 3 unformed bowel movements within 24 hours. Again, risk factors for CDI, certainly having systemic presentations as noted here. And again, patients who have had disease who have not responded to disease still have clinically significant diarrhea are patients that we want to look at very much. Again, we make the point that when it comes to the issues related to performing the test, do not perform the test on everyone that has diarrhea. We need to focus on other epidemiologic considerations. Can you advance the slides? Thank you very much. So there have been several important publications that can be noted. I just picked one from Carrie Ann Burnham and Dr. Bayuki, concerning the issues related to careful selection of patients. Appreciate that many of our patients in hospital are receiving laxatives. Tube feeding, certainly, change in tube feed, change in the quality, consistency of tube feeds can certainly cause diarrhea. And then again, this concept of what's significant diarrhea in hospital quantified as greater than 3 unformed stools. There's another paper just recently presented in Itchy, and it just calls our attention to the overall use of laxatives, pre-hospital admission, pre-diagnosis of CDI. Again, data suggesting here that diarrhea resolved within 48 hours in 41 patients who had received laxatives within 24 hours of being tested. Those included those patients who didn't receive CDI therapy. So again, the important suggestion that the cause of diarrhea in many patients undergoing C. diff testing may be non-infectious. And a real challenge with continuing the laxatives, albeit unknowingly, in our patients who have CDI, is that it might delay what is perceived as the response to therapy. And that has important implications for overall duration of therapy, and it has important implications for retesting. As my colleague said very, very clearly, in the addition of do not perform the test, there is support in the guidelines for not testing asymptomatic patients, and again, not performing retest within 7 days of the same episode. So again, if you're fighting those battles at hospital, then the guidelines will provide some support for that. My wife is a clinical microbiologist and also is a person who does IT now. And so this is a program that they implemented at their hospital, I think, several years ago. We are now seeing this done more and more frequently at hospital. But as Nate said, it's important to try to engender change, to try to minimize, the tiredness of going through screens. But asking some of these questions could be important, making decisions about the sending of tests and the initiations of therapy. Asking questions about, is the patient on tube feeds, laxatives. There's a whole host of other pro-GI motility drugs that need to be asked about and questions that can be asked. There's a reflex order for the isolation precautions to be generated upon the order for the test. And so that's important because infection control gets notified very, very quickly. But what they've done is they've also put in an automatic stop order for C. diff testing if the patient hasn't produced a qualified stool within 24 hours. And we said that many patients at hospital in that previous data set showed that they didn't have significant diarrhea. So this stops the test. They believe it might stop about 20% of the test from being actuated. And then there's a subsequent trigger to ask infection control to go back and review the isolation status. We know that keeping patients in isolation status is probably not the ideal situation relative to the quality and efficiency and cost of care. So if some of those statuses can be removed appropriately, then I think that improves the situation within hospital. The issues related to stewardship and what are the important ancillary treatment strategies, you know these very well, but again, support for the idea of discontinuing the inciting antibiotics whenever possible, using the shortest courses of antibiotic therapy if antibiotics are necessary during the concurrent management of CDI. And perhaps on the antibiotic side of the business, the largest changes that have occurred with this table. If one looks at the initial episode for non-severe patients, and it provides some of the supportive clinical data for this intervention in addition to the number of unformed stools, what you see is an obvious change in that the first-line agents now are vancomycin and fidaxomicin, and metronidazole has been relegated to an agent that should only be utilized if the other agents are unavailable. And this change is predicated on the statement that I've included above, and it's in the guidelines. And it asks the question, what are the best treatments of an initial episode to ensure resolution of symptoms and sustained resolution 1 month after therapy? And that is about keeping patients well and minimizing the numbers of recurrences. And we know from the data, they're cited in the guidance, that metronidazole has been challenged relative to vancomycin for recurrences. And we also know the data since the introduction of fidaxomicin that relative to vancomycin, in the 2 registrational trials, we saw an improvement in what was considered to be sustained clinical response. That was people that were well at the end of therapy and went on not to have a recurrence within that initial window of 1 month. So this is an important change, mitigating the use of metronidazole and elevating fidaxomicin to a first-line agent. If you look at the issues of episodes of severe disease, again, you see the same kinds of regimens. And then the initial episode of fulminant disease, the utility of vancomycin plus or minus metronidazole, particularly if the patient should have an ileus. Information about first recurrence here, and again, this is continuation in adults. Vancomycin utilized in the case of metronidazole for initial episodes. The use of a prolonged and a pulse tapered type regimen with vancomycin has been advocated strongly here in the first recurrence. Again, the challenges here, I think, are medication adherence and compliance with a somewhat challenging regimen. And then fidaxomicin has been noted here as a agent with utility for first recurrence. Similar philosophy with second and subsequent recurrences. Again, what's done with vanco is you move right to the taper or the pulse regimen. You can use fidaxomicin in this case, or the second noted is vancomycin for 10 days plus a rifaximin follow, 400 milligrams 3 times a day for 20 days. I also call your attention to one of the other hot topics, and that is the fecal transplantation. And it's important. It is noted in the guidance, and I highlight for you that this is the opinion of the panel that appropriate treatments for at least 2 recurrences. So this is 3 cases of CDI should be attempted prior to offering transplantation of fecal material. So again, this is the guidance from the expert consensus. I suspect many of you have some different ideas about the right patient for that. We didn't want to forget the importance of managing CDI in children, and in this instance, you see some similarities to what was previously available, and I think what many advocate, that is metronidazole is used in this situation, plus vancomycin, and you can see the utility of vancomycin with or without metronidazole for more fulminant disease, as noted here. I call your attention to the first slide we showed relative to treatment and the importance, as the guidelines highlight, keeping people well and minimizing recurrence. And I think we can't discount the impact on patient relative to recurrence. And I think we need to consider what are the best practices to mitigate recurrence. We talk about some of the data and the quality of life being 46% lower in CDI patients versus general population. And this was a little surprising to me. The data, 75% of CDI patients reported in a survey that the negative impact on mental health, primarily due to future concerns of health complications and or recurrence. So we can't discount the importance of making good decisions for patients and thinking about the overall management of the disease. Part of the question in the management is, does recurrence of potential disease, does it impact your choice of initial empiric therapy? And will you follow the guidance which makes some suggestion that that's an important consideration? One of the aspects that's not in the guidelines, again, an agent that was approved in 2016, a monoclonal to assist with the prevention of recurrence, Zimplava. And so again, we're asking ourselves where these new medicines fit in to our patients with CDI, and unfortunately, the quest will continue because the guidelines don't provide definitive data. If we look to the last slide or two, again, important comments relative to the prevention of CDI. We appreciate that transmission within hospitals represents a major source. Nate made the important point that another major source is what comes from within and what we bring to hospitals, certainly. But we need to look to prevention strategies, and hand hygiene policies are something that we struggle with optimization at hospital. Nate made the point that there are some important changes. We still want to have the manual manipulation of soap and water to kind of dislodge the spores, but there's an advocacy for alcohol hand hygiene as well, and it may be more readily available. Durations of isolation are important not only to minimize spread, but to get patients back in an environment where the quality and efficiency of care is improved if they don't require isolation. Environmental cleaning practices, the importance of detection and how you detect these potential patients with C. diff, what testing you're using, whether you're going to consider some interventions in the pre-hospital phase or the early hospital phase relative to understanding if patients are carriers of disease. And then, again, the antimicrobial stewardship based programs to reduce unnecessary antibiotics, reduce the duration of antibiotics whenever possible, and think about some of the non-antimicrobial interventions that were mentioned earlier today. And so again, the last slide here, when we talk about managing the impact of C. diff in the hospitalized patient, think about what would be your best practice. Think about what the opportunities are in hospital. Think about what we need to consider the non-infectious sources of diarrhea, the CDI prevention strategies, the programs of stewardship and infection control, the importance of the laboratory, to help us define the infected patient with a very rapid opportunity, the prompt initiation of appropriate treatment, and then when patients leave, we know that they are going to be concerned about the potential recurrence, and so we have to be sensitized about how we're going to manage them in the outpatient setting and make them aware of the potential concerns of use of antibiotic, especially unnecessarily in their future days. Thank you very much for your attention, and we'll turn it back over for questions.
Great. Thank you very much, Dr. Nicolaou and Dr. Ledebor. We do have just a few minutes to take some questions, and it looks like we do have some in the queue. As a reminder, if you have a question, you can click on the Q&A widget at the bottom of your screen. If we don't get to your question today, we will work with the speakers to respond to as many of those additional questions as we can via email. So to our first question, and it looks like Dr. Nicolaou, this one is for you. They're asking, what testing workflow does Hartford Hospital use? Do they perform algorithmic testing or standalone PCR?
Yeah, so we are currently a standalone PCR approach, and again, at some point, I forget the actual time that we made that change, but we had a two-tier approach with a toxin-based approach. But again, there was a need for increasing confirmation of those tests that did not provide definitive endpoints, and the decision was made to just make a transition to PCR-based approach.
Great. And then the next question is, I believe, probably for Dr. Ledebor on this one. If NAT-positive patients who don't have CDI can be associated with C. difficile transmission, is there a danger that by adopting a more restrictive testing strategy, in other words, by relating to preceding laxative use or restricting your specimen testing, that unrecognized spread may occur to others? Does that make sense?
Understanding the area of who are reservoirs within the hospital is still an area of very, very active research within healthcare institutions. Some of the newer literature would suggest that, in fact, patients that are carriers are an important reservoir for the spread of C. difficile, and identifying those patients may be important in terms of implementing a strategy for effective prevention of the spread of C. diff within the healthcare environment. So whether or not that's going to lead to surveillance testing or not, and whether, what should be done with these patients is really an area of active research. I would make the suggestion, so we are a healthcare institution that does a two-step testing. We do NAT followed by confirmation with EIA, and then we interpret that correctly. Anybody within our healthcare institution continues to be isolated if you're NAT positive. So I do think that there is a lot of evidence that would support the idea of isolating patients that are NAT positive, in large part, even though they may not be symptomatic, they may be a reservoir for disease.
Okay, great. And then I've got probably another one for you, Dr. Ledebor, a tricky NHSN question. So can you choose to do NAT on specimens for day 1 and 2, then if a specimen is sent in on day 3 or later, do NAT followed by toxin? Curious as to how NHSN would calculate SIR.
So the way that NHSN recommends that you choose your testing methodology in terms of calculating your SIR is the most prevalent method. So whichever method you use the most or is your predominant method. So that doesn't preclude you from using another method, but you ultimately would need to go back and look at your data and look at which method am I utilizing most. I would say that probably, in reality, if you told NHSN that, hey, I'm going to test with NAT for days 1 and 2, and then I'm going to move after that to NAT plus EIA, I'd guess that they'd probably say that's not within the spirit of their guidance. But again, based upon some of the questions that we've asked, because we do have different patients and we do have different testing methodologies, they've told us that when we report, use the dominant method.
Okay, great. And then a question about newborns. I understand some newborns are colonized with C. diff. What is the minimum age recommended for C. diff testing, assuming the patient has all associated symptoms? So another one for you, Dr. Ledebor, I would think.
I believe the data, and there's been some recent studies on this question. A lot of the package inserts, and Zach, you could probably comment on the Gene Expert package insert, but a lot of the package inserts suggest children less than 2 need to have a careful evaluation of when testing should be performed. I can tell you that even by the age of 1, many infants will begin to lose their colonization. So again, a lot of this is going to be based upon clinical judgment in terms of do the symptoms fit? Is the pretest probability for disease high, and then making a decision based upon that.
Okay, great. Thanks for that, Dr. Ledebor. Is there a specific recommendation not to test on patients that have received laxatives within 48 hours of testing? I've heard conflicting information, is the question.
So there isn't a specific. The idea of treatment ultimately is based on the severity of disease and the likelihood that it is truly infection. So these are considerations for withholding the test. But to my knowledge, there's not an absolute recommendation that says if they're on laxatives, don't test the patient. We have to use good clinical judgment. And when in doubt, again, because of the potential morbidities and mortality of managing C. diff, we need to incur testing and initiation of therapy in that at-risk patient. This is a consideration in patients that might not fit the profile for testing.
Okay, great. And anything to add to that, Dr. Ledebor?
No, I think Dave answered that actually quite nicely.
Okay, perfect. Well, we're just about at the top of the hour here, so I think we're gonna cut it off here. I want to thank Dr. Ledebor and Dr. Nicolau. If we didn't get to your question, we will try to follow up with a response by email in the next few days. As a reminder, a replay of the webcast will be made available later this week. If you dialed in later, have colleagues who might be interested in watching an on-demand replay. I'd like to again thank our speakers, Dr. Ledebor and Dr. Nicolau, for their excellent presentations, and thank everyone who took the time to join us today. We hope you enjoyed. Have a great rest of your day.